Welcome to the lecture for Psych 310. We're talking about dissociative disorders and somatoform disorders. So one of the first questions you might have is, well, why are these two different classes of disorders in the same chapter? Why do we talk about them together? Well, a lot of it is because our early knowledge of both of these groups of disorders come from the same source, and that would be the cases of hysteria that people like Freud and Charcot worked on around the turn of the century, where people had a variety of symptoms, usually physical in nature, sometimes paralysis, sometimes blindness, sometimes other physical symptoms that couldn't be explained by any kind of recognizable medical condition. They seem to have a psychological origin. And these people also experienced bouts of amnesia and experiences of fainting and losing kind of awareness of where they were and who they were, which now we'll talk about being dissociation. And these symptoms were thought at the time to be ways of dealing with trauma, or from a psychodynamic, psychoanalytic perspective, threatening impulses from the id. Right? So there were these sexual or aggressive impulses that they unconsciously had that they couldn't deal with. They were too threatening to admit into their awareness via the ego, so the impulses were converted into these other symptoms, both in terms of dissociation and in terms of expressing physical symptoms. So that's why they're in the same chapter, and they both seem to be sometimes, for some people, different ways of dealing with traumatic or stressful events. So we'll talk about dissociative disorders first. And when we talk about dissociative disorders, we first need to make sure we understand what is meant by dissociation. So, simple definition: dissociation is a disruption in the usually integrated functions of consciousness, memory, identity, or perception. So that's a nice fancy way of saying that usually we know where we are, where we've been, who we are, and what's going on. And all these things are related. Part of knowing who you are involves knowing where you've been and what you see or hear. So who you are, what you remember, what you're seeing now, they all work together to give rise to one unified consciousness. You are you. You remember where you have been. You know where you are. You know who you are, and all the things are working together. And dissociation implies that some of those processes have been separated, are currently separated, or have been separated at some point in the time, to where they're not fully integrated, so that some things you've seen or are seeing aren't accessible to your current awareness. So you might have a hysterical blindness they used to talk about, where your eyes are working fine, but you can't see anything, or may just be certain things that you can't see. Would be one type of dissociation, or there's certain things you can't remember. So memory has dissociated from conscious awareness. So think about dissociation being like disassociated, so separated, a separation of parts of consciousness. When we talk about three different aspects of dissociation, we're talking about the disorders. One, depersonalization, the kind of I'm not me feeling. This is when a person loses a sense of their own reality. So in these instances, the world is still real, but you're not. You lose a sense of who you are. So this is like when you feel like you're watching yourself in a movie or in a dream. So in the dream, it's the real world, and there's people, and you know them, and you may recognize them, and they all seem normal, and you even see yourself. But how can you see yourself if you are yourself? So you get that sense of a loss of the sense of who you are. Not you've forgotten who you are, but it feels like you're not yourself, but you're watching your own actions play out in front of you. Like if you've seen the movie Being John Malkovich, where they climb into John Malkovich's brain. That would be kind of a depersonalization, where you're seeing things, but you know it's not you. You're getting the inputs, like you've plugged a cable into somebody's head, and you're seeing what they see and hearing what they hear, but it's not you. That would be depersonalization. Derealization, similar, but a distinct process. This is you're real, but the world doesn't seem real now. So the world seems like it's dead. Like I'm me and I'm walking around, but this isn't the real world. It seems like life has been sucked out of it, and all these people are robots around me, and they're not. I've been in the real world, and this isn't it. Or I feel like I've been transplanted to some sort of bizarro world, some sort of alternate universe, where I know who I am, and I'm seeing this stuff, but this stuff isn't real. It doesn't feel real, and feel in terms of the very kind of subjective sense, cognitive, but also emotional thing. So depersonalization, derealization, and then third would be amnesia, which is probably the easiest one to understand. You can't remember. So, and the thinking with dissociative amnesia is that either at one time you remembered something and then the memory became dissociated from your consciousness, or more likely, when the thing happened that you can't remember now, you dissociated. You experienced depersonalization or derealization at that point in time, and so the memory didn't get encoded. So, like if you ever been watching TV, a really good show, maybe somebody tells you to take out the trash, and you hear them, but your attention is pretty focused on this TV show, and so you don't process it very deeply. And then later they say, "Hey, you take out the trash?" You say, "No, why? Did you want me to?" So that would be a very light version of amnesia, where your attention, so something came in and was processed by your senses. You heard it, you smelled it, you saw it, but it didn't get past a certain level into the brain, it seems, or is inaccessible from where it is at the moment. So when you can't remember an event, it seems to be the memories was not stored. Some either wasn't stored at all, or wasn't stored in the typical way where it's easily accessible. So these are things that, again, parts of the normal human experience. If you've ever zoned out, right? If you're driving, maybe you're going on vacation, and it's during the week, and you find yourself pulling out of your neighborhood and turning to go to work or to school, and then realizing, oh wait, I'm not going there. I'm on vacation. What was I thinking, right? Where you kind of dissociated for a minute. You had a purpose. You knew what you're doing, and then you can't remember maybe turning or why you went that way. You kind of got in this habit, and we have some automated thought processes where you get these routines, and you kind of lose a sense of where you are and what you're doing briefly, or experiences of deja vu. They seem to be somewhat related to experiences of dissociation, where things seem a bit unreal. Like, oh, have I been here before? This seems like I've seen this before, or I knew this was going to happen, but it doesn't quite seem real. So that's related to the experience of dissociation. And obviously, with not remembering things, most of us can identify with that. So again, pieces of normal human experience, but differ when it becomes a disorder in terms of the degree of dissociation and the amount of impairment and distress it causes. Okay, so the dissociative disorders we'll talk about are depersonalization disorder, dissociative amnesia, dissociative fugue, and dissociative identity disorder. Okay, so we'll take these in turn. Depersonalization disorder, characterized by persistent, recurrent experiences of feeling detached from and as if one is an outside observer of one's mental processes or body. So, more than one experience of depersonalization, right? That's the key feature of feeling like you're outside of your own body or your own awareness, and you're watching yourself somehow be yourself. So it happens more than once. It's persistent or recurrent, not just one time. Not enough to get a diagnosis. It has to happen more than once. And then to rule, and that's the key feature. But to then rule it out from other stuff, we have to say, well, the depersonalization experience, when it's happening, reality testing remains intact. By reality testing, you know it's not real. So you might feel like you're watching yourself on TV, but if anybody asked you, so were you really watching yourself on TV? No, I wasn't, but it felt that way. So there's this sense of unreality, but you still at some level have this kind of cognitive awareness that it's not reality. If you lose that sense of what is reality and what isn't, and you can't tell the difference, then we're moving into psychosis, right? Kind of delusional disorder, schizophrenia type stuff. Depersonalization disorder, not there. You know that it's not real. It just you know that you're not watching yourself, but it feels that way. It's all about the subjective experience. And also, obviously, the depersonalization causes clinically significant distress or impairment. So if it happens a lot and you find yourself zoning out a lot, if it's not getting in the way of stuff, and you're maybe just kind of a daydreamer and you maybe even enjoy it, then it's not a disorder. It's only a disorder if it causes a problem. And then another set of rule-out criteria. The depersonalization does not occur only during the course of another mental disorder, because it happens for some people who suffer from schizophrenia. So if you have schizophrenia and you have experiences of depersonalization, then it's not schizophrenia and depersonalization disorder, it's just schizophrenia. That happens to be one of the symptoms. But if you have depersonalization without the other symptoms of schizophrenia, then it's not schizophrenia, it's depersonalization disorder. Also, panic disorder. People, if you remember, we talked about panic disorder before, some people experience depersonalization, derealization during a panic attack. So when their heart starts going and they start breathing faster and they feel like they're going crazy, they may start to dissociate and feel like they're watching themselves have a panic attack. If so, it's not depersonalization disorder. It's still panic disorder. That happens within the course of that disorder. It also happens with PTSD, right, with flashbacks. Depersonalization and derealization, and also dissociative amnesia happens in PTSD. But if it happens only with PTSD, then it's not this disorder. If the PTSD, if the panic disorder are treated and you no longer have panic attacks, but you still have experiences of depersonalization, then it might be depersonalization disorder. But if it only happens in the context of another disorder, then that other disorder accounts for it better. It's a piece of another set of symptoms. But if you don't have those other symptoms, you just have this one symptom of recurrent depersonalization, then we will term it depersonalization disorder. One more thing to note just about the experience of depersonalization disorder is that individuals who are diagnosed with this also tend to have attentional difficulties, even when not having episodes of depersonalization. So they have a harder time tracking and paying attention to things. This shows some attentional deficits, common with ADHD, which may indicate, in a very kind of using kind of crude metaphor, this faulty wiring, where the connections among different parts of the brain that give rise to consciousness, something isn't working quite right with them regularly, and then there's certain times, usually during intense periods of intense stress, where the system gets overloaded and things really get separated or dissociated, and you have that experience of depersonalization. Okay, dissociative amnesia. The next one, obviously, the key feature, the predominant disturbance, is one or more episodes of an inability to recall important personal information, usually of traumatic or stressful nature, that is too extensive to be explained by ordinary forgetfulness. So we all forget things, and some of us more than others. But still, there's kind of this continuum of ordinary forgetfulness. But then beyond that, we have the extraordinary or unordinary forgetfulness, where if you can't say at all what you did yesterday, that would be extraordinary. If you can't say with clarity what you did 3 months ago to the day, three months ago today, exactly, what did you do that day? That's probably not dissociative amnesia, right? That's ordinary forgetfulness. But if you say, okay, about 5 years ago, where did you live? Most people can recall where they live, right? And assuming you haven't moved, 1,000 times, you know that information, right? It's personal information that we can usually pull up pretty easily. So this is beyond ordinary forgetfulness, where there's really these holes in memory that that are not just, oh, I can't remember the periodic table. Again, it's personal information about yourself, who you are, what you did, where you lived, who you were with, blocking out those things. And usually, again, it's related to stressful or traumatic things. So if you were in a car accident and have no memory of the car accident, that might be dissociative amnesia. I hope you remember from when we talked about PTSD that inability to recall important aspects of the traumatic event is a symptom of PTSD. So dissociative amnesia in the course of PTSD is a symptom of PTSD, and it's not dissociative amnesia too. So one of the rule-outs is, well, this forgetting, this amnesia doesn't just happen in the course of certain other disorders like dissociative identity disorder, dissociative fugue, PTSD, acute stress disorder, somatization disorder, and it's not due to a drug. It's not a blackout from drinking too much or getting stoned. It's not due to a general medical condition, a brain tumor, where there's not a medical cause, and it's not due to one of these other disorders. So it's having this symptom without the other symptoms that would merit diagnosis of a different disorder. So it's just the forgetting without the other stuff. And then obviously it causes clinically significant distress or impairment. One other kind of step back for a minute. One other disorder that you can have and have dissociative amnesia that may co-occur with some frequency would be borderline personality disorder. People with borderline personality disorder tend to have some individuals with borderline personality disorder have dissociative experiences, and one of the common ones is dissociative amnesia. But as we'll see later on down the road, some people with borderline personality disorder actually, if you spend enough time to find out, you'll learn that they meet criteria for PTSD, at which point they would no longer meet criteria for dissociative amnesia because it happens in the course of the PTSD. People that have this diagnosis, who are diagnosed with this, research has found that they tend to be highly hypnotizable, which I mentioned before, which is true of individuals with any of the type of these dissociative disorders we're talking about. They'll be higher in hypnotizability and measures of abstraction than other individuals. Okay. Dissociative fugue, which is kind of like dissociative amnesia plus. So this is sudden unexpected travel away from home or work with an inability to recall one's past. So there's some dissociative amnesia here, but also travel. That's what fugue means is flight. So you left wherever you were, and you can't remember stuff. If you didn't leave, it's just dissociative amnesia. But if you left, now it's a different disorder. Which seems a bit silly. But other criteria, there may be confusion about personal identity or assumption of a new identity, which may be partial or complete. So let's say you're living in Killeen, working at the gas station, and then you one day your family finds you're gone, and they find you 3 months later living down in San Antonio, working at the dog track, and your name before was Stan Jones, and now you're Stan Smith. So maybe you kept part of your name, but not the other part, and not because you think I'm going to change my name and hide, but you can't remember your name. Oh, I think it's Stan Smith, Stan Jones, whatever. So you may partially adopt a new identity, where you keep some parts of your old self. Oh, I know I like to watch football. Right? I can remember that about myself, but I can't remember if I have a family. So you may remember parts, but not all, or it might be a complete new identity, which is assumed, which is somewhat rare. Interesting though, whenever people do adopt a new identity in these cases where they've been discovered, usually at police stations or ERs, or when they've been reported missing, people track them down, their new identity is usually more gregarious, more outgoing, and less inhibited than their typical self, which might be telling in terms of what's going on. So if somebody's living a very kind of repressed, boring, dull life, and they're very closed off, and they want to be different, but they don't feel like they can be different, there might be part of them, consciously or unconsciously, that seeks out this other self, this other part of themselves, which is the life of the party, the fun, outgoing person who doesn't care what people think. And it seems to be that, people who are outgoing don't run away and then create this new identity of someone who's very shy. So it's interesting. Some rule-out stuff. It does not occur only during the course of dissociative identity disorder, because obviously, as we'll see in a little bit, dissociative identity disorder involves having a kind of a different personalities. It used to be called multiple personality disorder. It's also not due to a substance, so you're not dropping shrooms or something like that, and it's not due to identified general medical condition, and it's also causes clinically significant distress or impairment. So dissociative fugue is incredibly rare. There's a 0.2% prevalence rate, so very few people diagnosed with this. Sometimes you hear about it in the media, somebody having dissociative fugue. A lot of the ones you hear about in the media, eventually you find out that they didn't really have dissociative fugue, they were faking it. They owed money to somebody, were unhappy with their life, and just left and started a new identity somewhere else, and then were found out. And when they were found out, they claimed to have this kind of, it's coming back to me now, and they claim to have dissociative fugue. And there are cases of people faking this, but then there are other cases where there's no clear reason why somebody would fake. They had maybe a fairly decent life, and their new life isn't much better than the old one, where we think, okay, well, this seems like a real thing, but it's incredibly rare, but interesting nonetheless. Now, the one that most people want to talk about, kind of the most interesting of the dissociative disorders, and the one that, if you meet criteria for this, kind of trumps all the others, because all the other dissociative disorders really are features of dissociative identity disorder, kind of the broad umbrella. And so if you meet criteria for this, you don't get the others too. You just get this big one. So dissociative identity disorder, formerly multiple personality disorder, right? But renamed because the research suggests that the key feature of DID is dissociation. It's not these multiple personalities. And there's debate about whether or not they are distinct personalities. The key feature is dissociation, and dissociation related to identity. So anyway, the criteria: presence of two or more distinct identities or personality states, each with its own relatively enduring pattern of perceiving, relating to, and thinking about the environment and self. So what's a distinct identity or personality state? Depends on who you talk to. Some people will talk about these distinct personality states being alters, where there's kind of your main personality and then various alternatives, which in short term referred to as alters. Sometimes the alters will differ in age from the main personality, maybe even gender. So there might be a woman, a middle-aged woman, who has an alter that is a big, strong, an angry man, but also another alter that's a small, frightened little girl. But you have to have at least two distinct identities or personality states where there's this kind of both a subjective experience of it being different, but also observers would say, okay, this person is acting differently now than they were before. And it's not just that they're in a different situation. In the same situation, this person is acting differently whenever I'm talking to them and they're in this state. And sometimes the transitions between or among alters are identifiable by things like eye fluttering, things that look like almost like they're going into a trance. With some people, it can happen very quickly. They'll blink twice, and then they'll be talking in a very different way. The tone of voice might be different. The language and the vocabulary used might differ. So at least two distinct identities. And one thing I want to talk about is, I want to mention here, is that usually whenever the cinema, the movies have portrayed multiple personality disorder or dissociative identity disorder, they've done it and they've called it schizophrenia. They've shown someone acting as if they have two different personalities, and they say, oh, they're schizophrenic. And as we'll see later when we get to schizophrenia, that's not at all. They're different things. Schizophrenia and dissociative identity disorder really don't have much in common. People with one don't typically have the other. People with schizophrenia don't have multiple personalities. They have sometimes exhibit some really aberrant behavior that is confusing to people, and they'll seem like, wow, they got a lot of different personalities in there. They don't. They have one personality, and they have some problems with their cognitions and possibly hallucinations and delusions, but it's very distinct from dissociative identity disorder. Okay. So, dissociative identity disorder, at least two identities, usually more. And at least two of these identities or personality states recurrently take control of the person's behavior. So it's not just that you feel like, okay, I'm a shy, rather inhibited person, and I feel like there's this extrovert inside of me that just wants to get out. And I can clearly feel that. That wouldn't be DID. DID is you're a shy, inhibited person, and then there's some sort of switching, and now you're an extroverted, outgoing person who is different from the other person. The same physical form, but your behavior is now different. Your thoughts, your feelings are different. And at least two of these different identities or alters are in charge of behavior, go out and act in the world at different times. Another criteria, there's an inability to recall important personal information that's too extensive to be ordinary forgetfulness. So there's some dissociative amnesia. And the thinking with this for DID is that people might wake up in bed next to a stranger and think, oh my gosh, who is this person that's in bed with me, and how did they get here? I can't remember that how this happened. And the thinking is with DID, you got in bed with that person when a different part of the personality was in control, and that there's not information shared across the different identities or personalities. And that will differ across individuals the degree to which information is shared, and that somebody is aware of what they did when a different personality was in charge. So inter-identity amnesia is common, but not always the rule. Sometimes they know, okay, yeah, I remember whenever the angry man was in charge, he got in a fist fight. So he told me about it. So there may be communication, but sometimes there's not. And to meet criteria, there have to be at least some instances of dissociative amnesia where you don't remember what happened or what you did. Okay. And then a rule out criteria, it's not due to substance or general medical condition. And that's DID in a nutshell. Which again, the name change is important because it seems to be, at least in the research literature, about dissociation and splitting off parts of identity that are incompatible. And it's usually, it seems like, not, when we have these two different identities, they're not two fully formed multi-dimensional personalities, right? Like, I talk to you as a person, you have a multi-dimensional personality. Sometimes you're happy, sometimes you're angry. Sometimes you're outgoing, sometimes you're shy, right? You have all these different aspects of yourself. They're fully integrated into one person. With these alters, they don't seem to be that way. They seem to be somewhat one-dimensional, where there's a really shy personality, and the shy personality is never outgoing. And then there's the outgoing personality, and the outgoing personality is never shy. So it seems to be it's not really different personalities in there. It's different aspects of the personality, of the identity, that are split off from each other, where you can only be comfortable having certain traits and characteristics in one setting, and kind of seeing that as one identity, and splitting off, dissociating it from these other aspects of the self. If you want to look a little bit more at DID, there's the Dissociative Experiences Scale by Bernstein and Putnam, which is a screening tool that's been used for DID, which it's not a diagnostic tool. So it's not, oh, well, if I'm high on this, I have dissociative identity disorder. But it is used whenever you're trying to find people with dissociative identity disorder, and also with any dissociative disorder, and you don't have time to do full-depth diagnostic work with every single person, but you get 1,000 college students and you want to find 10 that have DID, you can give them this tool, and maybe you'll bring back 100 out of 1,000 that score high, and then out of the 100, there might be 10 that actually have DID, and the rest don't. So it's not diagnostic, but it is a screening tool that's used. And high scores, people that score high on this measure, 17% of them in one study, in the Bernstein study, actually had dissociative identity disorder. So if you want to look at this, here's the website, counselingresource.com/quizzes/DES, which stands for Dissociative Experience Scale, /index.html. And you can look at the diagnostic tool yourself and kind of get maybe a better feel of what kind of things are they asking people about to determine if they're at higher risk for having dissociative identity disorder. So it has to do with a lot of stuff about in terms of abstraction and getting lost in thought, in fantasizing, and not so much about just are there multiple people inside of you. It's not quite that simple. Okay, so for the skeptics out there, hopefully and hopefully most of you are skeptics. The question occurred to you: well, is this even a real thing? Is this a real disorder, or is this something that's been created? So one of the questions that comes up is, well, are people faking? Are they just faking to get out of stuff? And some people, yes. One of the most famous would be the Hillside Strangler. He faked having dissociative identity disorder. They found all these psych textbooks in his cell, and one way to define it that people are faking is to kind of subtly give them false information about disorder. And they say, oh, well, a lot of people that have DID also report that their dreams are in black and white. And then the next day I ask, okay, tell me about your dreams. Oh, last night I dreamed all in black and white, which has nothing to do with DID. It doesn't even really happen. So there are these kind of subtle ways of interviewing people to figure out if they're faking or not. And yes, some people have been found to fake dissociative identity disorder. Usually when they had a good reason to, like the Hillside Strangler, trying not to get executed, right? Trying to establish kind of an insanity defense, which, as we talked about before, is rarely used and rarely successful. It wasn't successful for him either. So, yes, people do fake it. But just because some people fake it doesn't mean it's not real. Just like some people fake having cancer, which seems horrible, and it is horrible to do that. Some people have been known to fake having these other diseases. Doesn't mean the disease isn't real. Same thing with dissociative identity disorder. Just because some people fake it doesn't mean it's not a real experience. So the other question is, if people aren't intentionally faking it to get something or get out of something, might it also not be real because it's created by therapists? Might therapists be planting the idea of dissociative identity disorder in people's minds? And one person who agrees with that to some extent would be Spanos. He talks about this sociocognitive model of dissociative identity disorder, which Spanos doesn't say that DID is fake. He believes that the symptoms are real. That people really do have these dissociative experiences. But he talks about the existence of alters being a product of interaction among the client, the therapist, and society. So there's this social cognitive process where social interactions and thinking about these terms gives rise to the belief that one has alters. And one thing that Spanos says to support this is that whenever if somebody talks about having an alter or two alters, if a therapist suggests, some people have many alters, it's pretty common that the person will then come back the next session and have more alters. So there are aspects of the experience that seem to respond to therapist input. And also, beyond the therapist, we also know about the influence of the media, kind of the social influence. Whenever there's a movie that comes out about dissociative identity disorder, formerly multiple personality disorder, the rates of diagnosis go up. Whenever Sybil came out, the numbers went way up, and it could be that people with DID are confused and don't know what to name it, and then they see a movie and they go, "Oh, that's what I have. That's the name for my experience, and I have just what they have." Or it could be people have these dissociative experiences that they don't understand, and the movie portrays a misunderstanding of it, and then they say, oh, this is what I have, even if they don't have alters, and they begin to say, I wonder who else is inside of me. Well, sometimes I feel like a scared little child. That's probably my child alter, and they'll begin to create this alternative personality in their own mind. And there is some evidence for this in terms of we can increase the number of alters in therapy by suggesting it. So people do respond to people who, again, let me slow down. People that experience dissociation and suffer from dissociative disorders of any kind are higher in hypnotizability and suggestibility than other individuals, which puts them at risk to develop kind of misunderstandings of things due to therapist suggestion. So people who have dissociative experiences, if a therapist suggests, is it possible you have alternative personalities, these people are more likely to accept that than other individuals. So there is some support for kind of Spanos's skepticism about the existence of these alternative personalities. Counter to that, there is some evidence for kind of identifiable differences among these alters. Talking about some people with DID, and it's not all of them, but some of them show differences in physiological measures, including EEGs, when in different identity states. So when they're the young boy or the older woman, their EEG looks different. And that's something that's hard to fake. But we don't know enough about the brain yet to be confident and say, okay, that's clearly a different personality state. It could also, these different physiological differences in physiological measures could also just be indicative of evidence of ability to concentrate differently when in different states. So that physiological data is a bit ambiguous, but it is still interesting that certain things that are hard to fake, they're different when you're in this personality state than when in this one. So the debate continues in terms of if it is, and not so much the dissociation. That seemed to be the existence of dissociation and problems with identity and not being sure of who you are. That's fairly well accepted in the therapy community and the research community. What's controversial is the existence of these alternate personalities. And then Gleaves and others have reacted with the statement, well, does it matter at all in terms of therapy? Not necessarily research, because for research, yeah, it matters to find the truth. But in therapy, does it matter if alters are real? And there are some that have argued that no, it doesn't matter, that your treatment won't differ if these are alters or if these are just kind of fractured pieces of a personality. You know, are you trying to reintegrate pieces of personality, or are you trying to reintegrate different identities? Either way, the reintegration process will be the same. The approach to treating people will be similar. We'll talk about in just a second. So the debate isn't over, and even I mentioned Sybil earlier, one of the most famous cases that was made into a movie. There's debate about that, about whether or not Sybil had alters, or whether or not they were a construction of her therapist. Part of it is there was a therapist who saw her briefly when her main therapist went on vacation, and that therapist indicated that the first therapist suggested and created these alters. But then there's questions about that person's motives, and we don't know. But what does seem to be true and real is that a lot of these people that are diagnosed with dissociative identity disorder aren't faking their experience of dissociation, and they frequently have some pretty horrific pasts. Like Sybil was the victim of really kind of unspeakable abuse at the hands of her parents. These kind of horrible experiences that make sense that they would have a profound impact on identity and holding your reality together. So these aren't people who are just faking to get attention. Horrible things have happened, and they've got some problems piecing together consciousness and who they are. So that is real. In terms of, are they really different personality states or just different aspects of personality? Not clear. But again, it may not matter. So let's look at the dissociative disorders as a group in terms of causes and treatments. In terms of causes, like most things, there seems to be a general biological vulnerability. Experiences of dissociation seem to have some heritability, runs in families to a degree, but usually, in terms of the kind of a diathesis stress model, you have to have a stress event. Most people don't have kind of happy-go-lucky lives and experience regular dissociative events. There's usually something really bad that happens. Could be kind of PTSD type stuff. Can also be kind of chronic abuse, where horrible things are happening or are about to happen, and you need to check out. You need to get your mind out of there and not focus on what you're seeing and feeling and smelling, all those things, and you need to go somewhere else in your mind. And if you do that enough, you might eventually lose control of your ability to direct what you're seeing, hearing, feeling, smelling, remembering. And so another thing that may contribute to a cause is a lack of coping skills. And we think of dissociation as a coping mechanism. So if you don't have other ways of coping with the horror of the trauma or the abuse, then this is kind of a last resort for some people. That, okay, well, I can't talk to anybody about it. I can't self-soothe by reinterpreting this event in some way. I'm not maybe abusing drugs, using some other coping mechanism. The body does this to protect the mind from further damage. In terms of treatment, depending on what the disorder is, you're generally going to look to identify the triggers. So what triggers your experiences of dissociation? If you're having recurrent experiences of depersonalization, derealization, going off into different identities, what makes that happen? So identifying those triggers and trying to find some way to neutralize them, which you can use some of the stuff we know from working with anxiety disorders in terms of exposing people to triggers. If you expose somebody enough, the trigger loses its power. But then also, like I said, for dissociative disorders, usually there's some stress event, some trauma going on. So the treatment, by and large, will involve processing the traumas. The treatment for dissociative disorders and dissociative identity disorder looks very similar to the treatments used for PTSD. If we think about dissociation being a way of coping with this traumatic event that you can't include as part of who you are and make sense of in terms of a piece of your identity, then the only thing to do is dissociate. But if we can get you to think about that trauma and let it become a part of your past, a memory that has a place in your life, then perhaps you will no longer need to use dissociation to cope with the painful emotions that come from the memory of the traumatic event. Okay, now let's talk about the somatoform disorders. So we talked about dissociation being the key feature of dissociative disorders. The key feature of the somatoform disorders as a group is the presence of a physical symptom or symptoms that suggests a general medical condition but aren't fully explained by that general medical condition. Briefly, the disorders we'll talk about are hypochondriasis, somatization disorder with the related diagnosis of undifferentiated somatoform disorder, conversion disorder, pain disorder, and body dysmorphic disorder. So the first one, hypochondriasis. Most people are familiar with the term hypochondriac. It comes from this diagnosis. So the key feature and number one symptom would be preoccupation with fears of having or the idea that one has a serious disease based on the person's misinterpretation of bodily symptoms. Okay, so either you're preoccupied with fears that you might have a disease, or you actually think you do have the disease and you're preoccupied with having it. So I think I might have it, I don't know, these things, or yeah, I have it, I definitely have it. Either way, it's based on a misinterpretation of bodily symptoms. And the symptoms might be symptoms of a real disease. It might be symptoms of a cold. They might just be normal bodily sensations, or there might be minor physical abnormalities. So if you When you're climbing stairs, if you get out of breath and your heart rate speeds up, if you've climbed 3 or 4 flights of stairs, that's what the body does, especially as you get older. But if you do that and you think, oh my gosh, my heart is beating a mile a minute, I can't breathe, something's wrong with me, I think it's a tumor. And that would be hypochondriasis. So it's not that you're feeling fine, there's nothing going on, you think, oh, I definitely have a tumor. It's asymptomatic. I have no symptoms, but I know something's there. There are symptoms. There are bodily symptoms that are real, but they're just misinterpreted. They don't mean what the person thinks they mean. And it's not just, oh yeah, I think I might have this thing, but whatever. You're preoccupied with it. It takes up a lot of your time thinking about having this disease or diseases or conditions. And then the preoccupation persists despite appropriate medical evaluation and reassurance. So maybe you have a spot on your skin. Well, that looks a little funny. I just saw this thing on TV that talked about these, misshapen moles. I think that might be cancer. I better get checked out. And you're worried about it. Maybe somebody died of cancer. Well, I'm really kind of freaked out about it. And so you have this high level of preoccupation, and you go to the doctor, and the doctor says, I think it's fine, but we'll biopsy it. They do a biopsy. Things come back, and it's benign. You say, oh no, it's fine. You don't need to worry about it. That would be appropriate medical evaluation and reassurance. If you say, no, the doctor missed it. I know they said it's fine. I know they said it was benign. But the test is only 99.9% accurate. It's 0.1% inaccurate, and I'm that 0.1%. I know that this spot means that I'm dying, that something's wrong. So there's a strong belief in the illness, that these symptoms are indicative of illness. But the belief isn't so strong. The preoccupation with the idea that one has disease, the belief in criterion A, is not so strong. It's of delusional intensity. And it's also not restricted to a particular concern about appearance. And we say it's not a delusional intensity because then it's a delusion and it's delusional disorder. So you really strongly believe it, but and this is just a matter of degree to where at some point you can say, well, maybe I don't, but it feels like I do. Somebody who's delusional is adamant, and there's no moving them off the point that yes, they definitely have the disease, and there's no way they could prove that they didn't have the disease. Someone with hypochondriasis might say, well, it might not be that, but then again, it might be this other disorder. So with enough evidence against one explanation, they'll come up with another one. So who's delusional is going to stick to that thing and going to hold it with an intensity that is qualitatively different. You can tell the difference talking to somebody with a delusion versus somebody who's just hypochondriacal. So it's not of delusional intensity that separates hypochondriasis from delusion disorder about being sick. It's also not restricted to a particular concern about appearance. If it's just my skin looks weird, it really looks weird and it really freaking me out, something's wrong with me, it looks weird, and it's just that thing about your appearance, then it might be body dysmorphic disorder, which we'll talk about in a minute. Hypochondriasis is usually more about illnesses and disease and not just about how you look. So this preoccupation, this fear and worry about being sick causes clinically significant distress or impairment, and it lasts a while, a duration of at least 6 months. And this is a fairly long duration for, a lot of the disorders say, well, it has to be at least a month of symptoms. For this, we say at least 6 months. I think it's because the people who determine this, I don't know if you know, determine all these criteria by taking a vote in a room with people. So, okay, all you experts, how many people think the symptoms need to last for 1 month? How many say 2? Do I hear 3? Do I hear 4? 6? 6 months has it. They voted based somewhat on research, but based largely on their own clinical experiences and their expertise. So it's a bit arbitrary, to be honest with you. But I think they moved this duration a bit longer than some others because there was a recognition and understanding that most of us will have concerns about being sick. And if you have some symptoms that you're not sure what they mean, it can be worrisome. And worrisome for some time, where I'm really worried about this. But then eventually, with enough medical reassurance, we can calm ourselves and be reassured that, okay, everything really is going to be okay. I'm not not dying. So a fairly long duration of symptoms to meet criteria for hypochondriasis. And then ruling out other disorders. So the preoccupation isn't better accounted for by generalized anxiety disorder. So this isn't just kind of one of many things you worry about. You know, with hypochondriasis, all your worry really is about having a disease. With GAD, you might be worried about paying the rent, about how your kids are doing in school, about how you're going to be evaluated at work. Oh, and also I have this spot I'm not sure about on my skin. That's just one of the things. If it's just one of the many things, it's GAD, not hypochondriasis. OCD can be hard to distinguish from hypochondriasis sometimes. If somebody has kind of contamination fears, so they're worried about touching things that have germs, and they have obsessions about that. That's OCD. Even if they have intrusive thoughts about this, like if it pops into their head, you're sick and dying. And the only way to relieve the anxiety from that is to wash their hands or count to 10 or do some other compulsion, and that would be OCD, not hypochondriasis. And it can be a subtle distinction between those sometimes. Also, panic disorder, we talked before about it may feel like you're having a heart attack. Somebody may think for a time that they have heart disease, but if it's recurrent panic attacks and you're worried about that, and just your understanding of it is, well, I think it might be an illness. It's not hypochondriasis, it's panic disorder. And then major depressive disorder, which we'll talk later, is characterized by major depressive episodes, periods of intense depression. They often have somatic symptoms where you may feel sick to your stomach and have a variety of somatic concerns. But if your worry about being sick goes away when you're out of your major depressive episode, because people who have major depressive disorder aren't always super depressed. Most people have inter-episode recovery where their mood comes up to normal or closer to normal for some period of time. When that happens, if your concerns about illness go away, it's not hypochondriasis. It was just due to the depression. And then other disorders, separation anxiety, somatoform disorder. So other disorders that also feature concerns about illness, if they're there, they kind of take precedence. And somatoform disorder, which we'll talk about in a minute especially, it kind of trumps all the other somatic disorders because it has a bunch of symptoms. But hypochondriasis is just generally worrying that you have a disease and being preoccupied. And again, it's about the misinterpretation of bodily symptoms. In terms of causes and treatment, like most things we talk about, a non-specific genetic influence. So and all that means is it seems to run in families to some degree. But it's probably related to the same type of thing in terms of anxiety disorders and ability to deal with stress. Because hypochondriasis, kind of like dissociative disorders, seems to be one way of dealing with stress. So, because usually people that lead kind of happy-go-lucky lives don't report hypochondriasis. The people that have had some major stressful events or some chronic stressor in their life, and this seems to be a way of coping with that stress and anxiety about something else. And the way we cope with stress and anxiety and the degree to which we experience stress and anxiety seems to be genetically influenced to some degree, as we've talked about before. Learning also probably plays some role in terms of having people talking about illnesses modeled for you. Because one of the things we know about people diagnosed with hypochondriasis is that they often report a history of serious illness in childhood themselves and or past experience with illnesses in other family members. So it might be that they were really sick before at some point in time, and the world treated them in a certain way, and there are certain benefits to that might make it attractive to talk about having disease if people pay more attention to you, that kind of thing. Same thing if you see other family members who are ill get any kind of special treatment or avoiding certain duties, you can see where that seems rewarding. We're talking about reinforcement here. That might make you more likely to cope with stress by somaticizing and thinking you have an illness and talking about, not keeping it a secret. People that have hypochondriasis don't really keep it to themselves. it's about sharing with others that you have this concern about being sick. And then also, as I've already mentioned, frequently people with hyperhidrosis report a history of a stressful life event, and disproportionately that stressful life event for people with hyperhidrosis seems to be some major loss or a death of a loved one. So it's something about being separated from ones we love, especially by death, that leads to this kind of concern with one's own health and possibly mortality. This person who I thought would always be there is gone. They got sick and died. Maybe I'm next. Maybe I'm sick now. Okay? That seems to happen. In terms of what can you do in terms of treatment, one thing would be symptom induction. Inducing their symptoms, showing them how it is possible to create their own symptoms. So if they talk about being out of breath, kind of like with interoceptive exposure with PTSD, have them run up and down the stairs and get out of breath and say, see, now you're out of breath. And you became that way after running up and down the stairs. That's a normal reaction. The way you're feeling, we can make you feel those things. And if we can make it happen, then maybe it's not because of some tumor or some internal disease process. Maybe it's a normal part of living. That can help some. And usually it's a combination of all these things in terms of the treatment approach. One other piece of the treatment might be challenging their cognitions about the illness. So, okay, you think that you're ill. What's the evidence that you're ill? What's the evidence that you're not ill? And just kind of having kind of a rational discussion with them, and not telling them, well, it says here you're not sick, you're not sick, you're not sick. It's asking them, okay, you say you're sick. How do you know? What's the evidence that you're sick? What's the evidence that you're not sick? Well, the evidence I'm not sick is this lab report says I'm not sick. Why might this lab report be inaccurate? What's the evidence that the lab is wrong? Well, I just feel it's wrong. Okay, well, and you talk about how feeling may not be the best way to predict the world. Talk about, is it always accurate? Whenever you feel something is a certain way, is that always right? If not, then you may not want to rely wholly on that as a way to live your life. Is there any evidence beyond feeling that it's not right? So kind of getting at the cognitions behind their preoccupation. And then also thinking about this as a coping mechanism. So give them some other coping skills. So do some stress management training, targeting their overall stress levels. Because if we can make you overall less stressed, less anxious, and with a variety of ways of doing that, emotion-focused, problem-focused approaches to dealing with stress, then you won't need to focus on these fears of illness. And sometimes people will get better with just reassurance by a mental health care provider. And sometimes this seems to happen partly due to the medical system we've created here in the States, where somebody has a concern about an illness and they go see the doctor, and the doctor has 5 minutes to meet with that person, and they say, okay, you see you have the symptoms, let's run some tests, I'll be back later, kind of better, no, you're fine, thank you, have a good day. And the person got the results, but they didn't get to talk about the results and how they feel about it and make full sense of it. So the reassurance by the appropriate medical investigation, what was the term? Medical evaluation and reassurance, they may not have really gotten appropriate medical reassurance. Dr. May just said, you're fine, have a good day. Mental health care providers receive more training in talking with people than physicians do. And sometimes if they can just talk with the person about the lab results and what it means, and sometimes that will help the person feel better enough about what they're going through to get a different understanding of it. And in terms of psychopharmacology, anti-anxiety drugs are sometimes prescribed. It's not clear yet the degree to which those are successful treating this disorder. So the jury's still out in terms of that, but it is one approach. Okay. So talk about hypochondriasis, now somatization disorder, which is the big disorder. If you meet criteria for this one, then you don't get any other somatoform disorder really. And it's a history of many physical complaints beginning before age 30 that occur over a period of several years and result in treatment being sought or significant impairment in functioning. Okay, so this is complaining about a lot of stuff, getting a lot of tests done, a lot of treatments, and as we'll see in a little bit, it's a lot of symptoms. So this is beyond just, I think I might have a disorder. I've got this weird thing. It's, I have this pain here, and I've got this here, and I've got cramping in my stomach, and I can't, and my vision is blurry. It's several symptoms. And notice that the complaints begin before age 30. Why is that? Why is that age thing in there? Well, as somebody who's over 30, I can tell you, because your body starts to go downhill a bit after 30. And the idea being that if it's a mental disorder and not just normal aging, then you're going to have these complaints earlier in life. And after 30, you might have multiple physical complaints that are valid and accurate. And it might be harder to distinguish mental disorder from real physical problems, just the product of aging. So it's something that starts fairly early in life. Think about it in terms of a person, almost like a personality disorder. This is a way of dealing with the world and a way of dealing with stress. Again, so it's something that starts early on, usually. So in terms of all the symptoms you have to have, so each of the following have been met at some time. So not all at once. You don't have all these symptoms at once, but you have a lot of symptoms over the course of the several years it takes to meet criteria. So usually this is a diagnosis that's made after somebody's seen doctors for a long time, and then finally some doctor says, wow, you've had all these tests done and all these workups and nothing's ever been found. I wonder if you might have somatization disorder. So unfortunately, something that's usually not diagnosed early, and by virtue it can't be. So at some point in time you had at least 4 pain symptoms, and they can be 4 different sites or 4 different functions. So it could be back pain, head pain, chest pain, pain during sex, pain during urination. And the head pain could be a unilateral headache, bilateral throbbing, an intense, sharp stabbing pain. So, but at least 4 different symptoms at some point in time. At least 2 GI symptoms, so nausea, bloating, diarrhea. At least 1 sexual symptom, which could be sexual indifference, so having no sex drive. In men, erectile dysfunction. In women, oddly enough, nausea throughout pregnancy is considered a sexual symptom. Irregular menses, also considered a sexual symptom. And then 1 pseudo-neurological symptom, which a pseudo-neurological symptom is a symptom that suggests a neurological condition that doesn't have a neurological basis. So blindness, paralysis, weakness, anything where it seems like there'd be something wrong with your brain or spinal cord, but there's really not. So at some point you've had all these symptoms. So that's what 8 symptoms, 8 distinct symptoms over the course of these years, and so you've had all these symptoms, and either after appropriate investigation, the symptoms that we just talked about, all 8 of those, can't be fully explained by a known general medical condition or the direct effects of a substance. So if you are having stomach pain and they find an ulcer, okay, that symptom doesn't count toward this disorder anymore. You have to have another GI symptom. So all the symptoms have to be not fully explained by a medical condition. That we have lab results to show, okay, you have this problem, you have this tumor, you have this disease, this infection, or a substance, some sort of drug or poison, allergy, whatever. So either that, or if there is a general medical condition, physical complaints resulting impairments are in excess of what would be expected from the history, physical exam, or lab findings. And this can confuse people sometimes. So you can actually be sick and still have somatization disorder? Yeah. So you might really have, let's say you have a tumor on your kidneys, and there's certain symptoms that might be associated with that. But if you have these other symptoms that are unrelated to that tumor and in no way makes sense given that tumor, you might also have, in addition to having renal cancer, you might have somatization disorder. So you might have other symptoms, or the symptoms might be too much. So if let's say you have a tumor on your optic nerve that, given its location and size, should cause slightly blurred vision. but instead of slightly blurred vision, you report periodic instances of complete blindness. And they say neurologically, that's not true. That doesn't work. We see when we do the brain scan, we can see your the cortex lighting up, indicating that you are seeing things. The images that are hitting the eye are getting processed in the brain, and you are processing visual information. It's clear that you don't have blindness, but you experience blindness. Then your symptom would be in excess of what's expected, given what I know about you medically. So you can have a medical condition and still have the disorder as long as your symptoms are excessive in terms of the degree of symptom or the number of symptoms. They all can't be explained by that medical condition. So you have all these symptoms, and they don't make sense in terms of any kind of general medical condition. Also, the symptoms aren't intentionally produced or feigned, so you're not knowingly faking them or producing them by poisoning yourself or punching yourself in the stomach. So you're not knowingly doing it, but it's not caused by a medical condition. The thing is, you are unknowingly or unconsciously producing the symptoms. So the symptoms aren't a result of disease; they're a result of the mind. And people that maybe have a hard time believing, well, how can you really know? They know they're doing it. There's no way you can make yourself sick. And we know that actually, yeah, you can make yourself sick. If you've known anybody that's ever gotten hives, that's kind of this medically linked condition where you have this release of histamine, and we can identify the chemicals involved, but there's no pathogen out in the world that causes them. It's not an allergic reaction to something in the world. It's stress, and thinking a certain way causes release of these chemicals and causes physical manifestation. Lots of skin stuff that is like psoriasis, not caused by stress, but certainly exacerbated. It gets worse in times of stress. So there is this mind-body connection, and there's plenty of evidence that we can make ourselves sick, and not when we're trying to, but just that's a way that for some people that's how their body deals with stress. It comes out in the form of physical symptoms. Okay, so this sort of, as I said, trumps all the other somatoform disorders. So if you have this, you don't also get hypochondriasis or pain disorder or the other disorders we'll talk about. If you have this one, any other disorders that it encompasses, you don't get the other one too. You just get this one. It's kind of the big one. Now, like I said, it takes several years to get diagnosed with this because it's a lot of symptoms. So frequently people that are diagnosed with this, before they get this diagnosis, they are diagnosed with something called undifferentiated somatoform disorder, which is kind of a lesser diagnosis. This is when you have 6 months or more of one or more physical complaints that don't have an identifiable cause. So you have 1 symptom, 2, 3, 4, until you get to the 8, you have undifferentiated somatoform disorder. Once you get to all those 8 symptoms, having the 4, 2, 1, and 1, you got all those from those categories. Then you bump up, you lose the undifferentiated, and you get the somatization disorder. Okay. So until then, you still can have a diagnosis so that you can get treatment, and they can do research on individuals by lumping them into a group together. Okay, so in terms of causes and treatments, causes, I didn't put here, but probably some sort of genetic vulnerability. There seems to be one commonality among those in this group is family history of illness, so kind of like hypochondriasis, the same kind of background where somebody in the family was sick. So that, in a way, it seems that there's this learning that they learned about being sick, and learned about expressing symptoms, and learned what happens when people talk about being sick, for good or for bad. And then, interesting enough, we're not sure what this means exactly, but it seems to be possibly linked to antisocial personality disorder, which we'll talk about later. Antisocial personality disorder is the personality disorder where people have a disregard for the rights of others. So most people in prison who don't care about anybody else, and they'll hurt anybody for their own means. Some CEOs who will do whatever it takes to make a profit, and they'll violate the rights of others. So they violate the dictates of society that say that you can't just do for yourself. That's antisocial personality disorder. It's linked to Somatoform disorder in terms of women with Somatoform disorder are more likely than the people in the general population to have a first-degree relative with antisocial personality disorder. Will suggest that possibly there's some sort of common some sort of vulnerability, biological, genetic vulnerability that is expressed differently depending on gender role. So if you have some way of dealing with the world, or maybe problems dealing with stress, we don't know. But if you have kind of the dictates of society put upon you as a man, where it's not really okay to complain about being sick, but it is okay to hurt others, and we kind of glorify others who are able to be aggressive and violent about the professional football. Kind of that's more acceptable for the masculine role. That might lead those individuals to seek out behaviors that lead to a diagnosis of antisocial personality disorder, and women where outward expressions of aggression are not tolerated. It's a violation of the gender role. So a different way to get needs met and deal with stress might be to experience these physical symptoms. Again, hard to understand, but there's just this piece of evidence that they seem related in terms of this familial aggregation of the two disorders, suggesting possibly some underlying similar pathology, but not sure what it means yet. In terms of treatments, no documented effective treatment. So there's nothing that we can say, oh, well, this definitely works. Really difficult to treat, and don't even speak of cure, but to treat. What strategies to reduce the impact of the illness on the individual, but also on the society and the medical system, is having the gatekeeper physician, which is what family practice, pediatrician, general practitioner doctors have traditionally been. Having, that's kind of for most people, to go see a specialist, you have to see your GP first and get referred. That's changing now somewhat, but for these individuals, sometimes that's imposed on them after they've sought so many specialists and used up so much, usually of the insurance company's money. The insurance company says, okay, you've had all these labs done and these treatments, and nobody's ever diagnosed you with anything definitive in terms of a medical condition. We're no longer going to pay for anything unless you get a referral from this doctor here. And this doctor is going to be the gatekeeper to make sure that you don't, go to one GI doc here, they won't treat you, and then you go to another GI doc here, and they'll treat you. So we're going to have this one gatekeeper that keeps track of all your stuff, so you can't doctor shop and get lots of procedures done. That's one way to manage the person's behavior. It doesn't really help them get better. It manages their behavior to some degree and protects the system. And in terms of helping the person, the other thing that we try to do is, again, reduce overall stress levels. If we think of this as a way of coping with stress, then let's teach you some other coping mechanisms and try to get your stress down so you no longer need unconsciously to engage in these behaviors or have these symptoms. The next one, conversion disorder, and this is the one that is most similar to what was previously referred to as hysteria. This is where people have one or more symptoms or deficits affecting voluntary motor or sensory function that suggests a neurological or other general medical condition. And that's a fancy way of saying motor and sensory functioning. So how you're able to move around in your senses. So impaired coordination or balance, localized weakness where just your left hand is weak, but no weakness anywhere else in your body. Loss of pain sensation in certain areas, double vision, seizures, blindness, loss of sense. Anything like that would be a symptom affecting the motor or sensory functioning, suggesting a neurological or other general condition. So you have at least one symptom, possibly more, and it's judged, just by clinician, that psychological factors are associated with the symptom or deficit because the initiation or exacerbation of the symptom or deficit is preceded by conflicts or other stressors. So that's the way of saying, well, you didn't have this problem until, so maybe you have hysterical blindness, you can't see, and you could see just fine until you walked in on your parents having sex. And then now you can't see, okay, that's conversion disorder. You didn't get acid in your eyes, there's no physical trauma, there's a psychological trauma, some sort of stressful event or conflict that preceded the symptoms. So that talks about the initiation of symptom. If we talk about exacerbation of the symptom, it could be somebody who has had maybe relational difficulties, and they recently got married, and whenever they need to go out in public with their spouse, they experience weakness in their lower extremities where they can't walk. And it only happens, or it gets worse whenever they have to go out in public with their partner. And whenever they're able to stay at home, it's fine. So the exacerbation, the worsening of the symptom or deficit is associated with conflicts or stressors. And yet, the symptom or deficit is not intentionally feigned or produced. So again, it's happening at an unconscious level. You're not faking that you can't walk or that you can't see. You're not trying to be that way. You're not knowingly doing it, but it's happening, and it's not explained by a general medical clinician. So after appropriate investigation, it can't be fully explained by a general medical clinician, a substance, or as a culturally sanctioned behavior or experience. So there's some cultures and subcultures where usually brief experiences of paralysis might be culturally appropriate. So if part of the culture, and usually religious experience, involves a trance-like behavior during any kind of religious ceremony, or the obtaining of visions, if it's in the context of that, somebody who's in that culture and that's how they understand it, then it's not conversion disorder. It's culturally appropriate. But then backing up a tick to the first part of that, appropriate investigation. So what's appropriate investigation? Well, it depends on what your insurance company will pay for, to be honest with you. So usually brain scans, maybe some neurological testing, doing psych assessments and stuff. If you've got the money for that, at least usually some sort of neuroimaging study to look if there's any abnormalities in the brain or tumors related to this symptom. How much investigation you get, again, depends on your insurance and how wealthy you are, and that determines realistically how much you're going to get in terms of how much is appropriate. That's up to a medical professional to decide on a case-by-case basis. Like most disorders we talk about, it causes clinically significant distress or impairment, or warrants medical evaluation. And then ruling out other stuff, it's not limited to pain or sexual dysfunction. Does not occur only in the course of somatization disorder, which we said trumps other things. It is not better accounted for by another mental disorder. So in the if it's just a pain symptom, that's pain disorder. Let's talk about it in a minute. If it's if you think about this paralysis being related to kind of erectile dysfunction, that's a sexual disorder, not conversion disorder. And pain during sex, as we'll talk about in a minute, is a separate disorder as well. So not any of those things, then it's conversion disorder. And beyond the brain imaging tests and medical tests, sometimes clever neuropsych evaluators have ways of figuring out if a symptom is consistent with the way the brain works, or if it's more consistent with conversion disorder. And one of the examples I always talk about is people that talk about having paralysis in their arm. And if you hold the person's arm hold their hand above their head, and then let it drop, if they have conversion disorder, their arm will fall to their side, limp. oh, that's paralysis, right? But somebody who really has paralysis, and don't do this, but somebody who really has paralysis, if you hold their arm above their head, with a hand above their head, and you let it drop, the hand will come down and strike them on the head before falling to their side. So most people have the kind of this unconscious self-protective motivation to where if they can help it, they won't hit themselves in the head. And again, they aren't trying to fake it, but there's enough of their mind that knows that they're not paralyzed to keep the arm from striking themselves if they have conversion disorder. And there are a couple different little tricks, I would say, but assessment strategies to distinguish between real neurological dysfunction and conversion disorder symptoms. In terms of causes and treatments, like I said, with a lot of these things, some sort of traumatic stressful event usually occurred, and for conversion disorder, it seems like the symptoms sometimes provided escape from the trauma. So like with the hysterical blindness, so you're seeing something that you don't want to see. Going blind is one way to stop seeing that thing, right? Or it could be also thinking about kind of dissociation. And if somebody who's in maybe a combat experience and other troops are being shot, and they should go to run toward the shooting, which runs counter to most self-preservation instincts, but they don't want to, and yet they don't want to. They don't want to see themselves as afraid or cowardly, and so they might experience a paralysis. Right? I couldn't run. I couldn't get there because I couldn't run, and I still can't run. I'm paralyzed. I must have been shot. I can't move my legs, and not being able to move your legs help them not run into the danger. So they escaped the stressful event because of the symptom, and not intentionally produced, but just the mind's way of protecting the self. And like most somatoform disorders, frequently a history of family illness among individuals with conversion disorder. So some role of those learning experiences. In terms of treatment, obviously they have to have appropriate medical evaluation first, make sure that it's not just a hard to diagnose medical problem. And then usually, like I said, the cause usually is related to some sort of traumatic event. So like with PTSD, like with dissociative amnesia disorder, you want to process the trauma. So you do that work just like with PTSD, where you go back to the traumatic event and work through it to where they no longer need to avoid the traumatic event and no longer need the symptom. And similarly, reducing the overall stress level reduces the need for the symptom. And lastly, you also want to reduce secondary gain. So people with conversion disorder aren't experiencing symptoms in order to get secondary gain. And secondary gain means getting paid, getting disability payments, getting out of certain requirements or duties. Right? They're not doing it for that, but they might get that stuff because of their symptoms. So if we take away all the nice stuff from it, that also seems to help with getting people, make it easier to give up the symptom and find another way to cope. Pain disorder. Obviously, pain in one or more anatomical sites is the focus of clinical presentation, and the pain causes clinically significant distress or impairment. And kind of like the last one, psychological factors are judged to have an important role in the onset, severity, exacerbation, or maintenance of the pain. So when the pain starts, or how severe it is, when it gets worse, or that it keeps going. So not necessarily though the onset, and that's kind of an important distinction to make. People with pain disorder frequently have real kind of organic pain. Something happened, they break their leg, they have an infection, whatever, and there's some pain. But with pain disorder, the level of pain isn't can be explained by the degree of physical harm to the body. It hurts more than it should, and whenever it starts hurting more, or it keeps hurting, it seems to be related to psychological factors in terms of stress or other relational factors, possibly, but something about how you're thinking, feeling, and behaving seems to be related to the pain. It's not being faked on purpose, and the pain's not better accounted for by another disorder like a mood or anxiety disorder, psychotic disorder, and does not meet criteria for dyspareunia. And dyspareunia, kind of alluded to earlier, that's pain during sex. It's listed under the sexual disorders. So if you only have pain during sex, that's thought to be a different type of thing and related more to sexuality than to just generic pain. So pain disorder, pretty straightforward. Pain seems to have some sort of psychological component. But it's causing distress or impairment, which it's somewhat silly to talk about. Well, this is pain that has a psychological component, because all pain by nature has a psychological component. You can't feel pain without a psychological component, because feeling is psychological, right? It's not physical. You know, the change in the release of chemicals is physical, but the subjective experience of pain is definitely psychological. So all pain is psychological. Pain disorders, whenever psychological aspects of the pain are pronounced. So in terms of causes, usually there is some real physical trauma. Quite frequently, back pain is one of the more common ones, and one of the ones that's harder to treat. So usually there's some physical trauma that leads to pain in the first place, and then psychological factors take over, and your pain doesn't resolve the way that it should, in the opinion of medical professionals. And one reason it might not resolve is because of kind of something we're talking about in terms of the pain cycle. So typically when we experience pain, we are given drugs, and they make the pain go away. Unfortunately, drugs change the way the body works, and they change the way the body responds to pain. Sometimes creating more pain in the long run. So they may make you feel better now, but if we stop the drugs, you might have developed kind of a hypersensitivity to pain and need higher levels of drugs. And once you stop the drugs, now even small things seem to cause more pain. In terms of treatment, one of the main goals frequently is medication reduction, trying to get people down to a manageable level of medication where they won't be gorked out all the time. So you want to, again, get their medication down to a manageable level, both so they're not so doped up they can't function, but also because we know that you can only escalate so far before we start causing some long-term damage to the body at high levels of pain medication or pain medication over a long period of time. Other things we can try to do, biofeedback seems to be helpful for some people, and there's different types of biofeedback, but generally it's hooking you up to a machine, usually a computer, that monitors some ongoing biological process in your body, galvanic skin response, heart rate, temperature, some measure of how your body's working, and then teaching people to get some control over their body's functioning, even autonomic functioning. So learning to speed up and slow down your heart rate. And they'll have things where it'll be like on the screen you'll see this little hot air balloon, and it'll be sitting on the ground, and it won't start flying until your heart rate slows. So when you sit there and you can slow your heart rate, the balloon will start taking off. If you can say, hey, look, the balloon's flying, heart rate goes up, the balloon comes back down, and you can kind of learn to have some control over your body. And the more people kind of experience controlling their body, they get more confidence in control of their body. And sometimes that leads to a reduction in the pain experience. Related to that, usually involves some relaxation training, because we know that stress is certainly related to the experience of pain. So if we can teach you to relax and reduce muscle tension, that frequently reduces the experience of pain. For some individuals, hypnosis is an effective treatment. I think it depends on level of hypnotizability to a large degree, but for some folks it is helpful in pain management. And then generally teaching stress management techniques with the understanding that stress contributes to the experience of pain. And just because stress contributes to the experience of pain doesn't mean the pain's all in your head. And even saying it's all in your head, usually people think, oh, if it's on your head, it's not real. Well, you know, if you love your parents, well, that's all in your head. You know, it's not in your heart. Your heart pumps blood. It is all in your head because who you are is all in your head. It's all related to functioning of neurons and these different pieces of the brain interacting in this electrochemical functioning. So saying it's on your head isn't in any way diminishing someone's experience. So pain is on your head, but it is certainly real, but can be managed better with a combination of psychological and biological interventions. Okay. Now one that maybe seems a little different from some of the others, body dysmorphic disorder, because this isn't so much about disease, it's more about appearance. In some ways sticks out, for me at least, from the other somatoform disorders. But body dysmorphic disorder is preoccupation with an imagined defect in appearance, and if a slight anomaly is present, the person's concern is markedly excessive. So if you think your ears are too big, your nose is too big or too small, and either it's an imagined defect, so your nose isn't really too big. Most people say, oh no, it's not big at all, it's a lovely nose. Then that would qualify for this criteria. But it can also be a slight anomaly, so you might have kind of a big nose or kind of small ears. But if your concern is excessive, if you're worried too much about it, that also meets criteria for body dysmorphic disorder. And then obviously the preoccupation causes clinically significant distress or impairment. But the preoccupation is not better accounted for by another mental disorder. Normally we talk about most frequent in terms of ruling stuff out would be anorexia nervosa. So if you have an eating disorder, and if you have anorexia, there's a preoccupation with being fat and even commonly focus on certain body parts. I think my hips are too big. If you're worried about your hips being too big, if that worry and that focus only occurs in the course of anorexia nervosa, then you're not diagnosed also with body dysmorphic disorder. It's just anorexia nervosa. But again, it could be any part of your appearance, something on your face, your legs. I knew one individual who felt their skin was imperfect and flawed and just disgusting to look at, and really beautiful skin. So any kind of imagined defect in appearance where they're overly concerned about it. So what causes body dysmorphic disorder? We don't really know. It's not well studied. They don't present to psychologists very often for study. They usually present to plastic surgeons. Talk about it a little bit. So not much data on them. There does seem to be some similarity to obsessive compulsive disorder, and we see that mostly because of some of the treatments that are used are similarly effective. Some of the drugs used for OCD are also used for body dysmorphic disorder and seem to work. And the obsession with the defect does have this obsessional quality that feels a bit like OCD, but again, it's still different because there aren't necessarily compulsions to deal with the anxiety, which is this constant worry and concern about looking a certain way. In terms of treatments, the antidepressants, selective serotonin reuptake inhibitors, which everything we've talked about so far pretty much people take SSRIs for, the wonder drug. Some success in treating symptoms with that. Another thing which makes us think seems a little like OCD, exposure with response prevention. So having them look at the imagined defect and kind of sit with it, because usually they'll try to hide it, disguise it, cover it. You may see big guys in the gym in the summer wearing sweats, It isn't because they're trying to necessarily, it might be, but isn't necessarily because they're trying to burn off body fat, right, by sweating more. They're covering up their bodies because they're ashamed of how they look, and they don't think that they're muscular enough, and they might have body dysmorphic disorder. They think their pecs are too small or their calves are too small, so they hide that part of their body. So we expose them to that part of the body and prevent them from covering it up and showing them, okay, look, keep looking at it. You're not going to die. You're not going to go away. You're not going to be destroyed. You go out in public like this, people aren't going to laugh and point. See, you're going to be fine. And that tends to help some with the experience of anxiety. As I said before, a lot of these individuals don't present to therapists. They present to surgeons to have these perceived defects corrected. And some people might think, oh, wow, body dysmorphic disorder probably is a good income generator for plastic surgeons because the people will always come back for more. Right? And it's true they will come back for more, but it's not really necessarily a good thing for plastic surgeons because they will never be happy with the work that's done. And they're at fairly high risk for suing you for malpractice, that you didn't do it right. And they won't ever be happy with the level of care they receive. Even if you think you've done a beautiful job reconstructing their nose or whatever, they'll still think it looks hideous. So a lot of, some cosmetic surgeons are starting to use screening tools to identify the level of concern people have about their looks, and to kind of screen out people that have body dysmorphic disorder and make sure that they're psychologically healthy enough to undergo surgery. Some of those surgeons do it to protect clients, but a lot of them also do it to protect themselves from lawsuits. Okay, so we've talked about all the different somatoform disorders, and we've always said, well, they're not intentionally producing the symptoms. It's all happening at an unconscious level. Sometimes people do intentionally produce or fake or feign symptoms. And there's two cases we'll talk about, one of which is a diagnosis, the other's not. The one that's a diagnosis is factitious disorder. Right? You may have heard of Munchausen's disorder or Munchausen's by proxy. And Munchausen's by proxy is what would now be termed factitious disorder by proxy, and Munchausen's would be factitious disorder. But factitious disorder is when somebody does either produce symptoms by poisoning themselves, injecting themselves with certain things, causing injury to their body in some way to create a symptom, or lying about something, just faking it. But they're doing it because they want to assume the sick role. They want to be the patient and be taken care of. And not taken care of in terms of, they're broken on the streets and they need a hospital bed. And there are cases of that happening. But they want psychologically, relationally, to relate to people from the point of view of a patient. And they feel that the only way to get kind of the care and nurturing they desire is to be sick. And this is a diagnosable mental disorder. And to have this, it's tricky to diagnose. For one thing, you have to first figure out that they're faking the symptoms, which can be hard to do if they're clever, do a good job at faking it. And doctors usually assume that their patients are telling them the truth. If you say you have these chronic headaches, they believe you have chronic headaches, and they are going to try to figure out why you have them. So you have to kind of work through the deceptions. And you also need to establish that external incentives are absent. So they're not getting anything out of this. They're not getting workman's comp or getting off of some crappy job. All they're getting is the attention that they get by assuming the sick one. And then factitious disorder by proxy would be the same thing, except for instead of producing the symptoms in yourself, you produce them in another. And usually it's a parent producing symptoms in a child. So poisoning a child or lying about a child's symptoms in order to get kind of care and attention from the nurses and doctors in a healthcare facility, which is a really rare phenomenon. It does happen, and debatable whether or not factitious disorder by proxy should be a mental disorder or just be termed child abuse. It certainly is child abuse. Whether or not it also is a mental disorder is debatable. But fictitious disorder itself, causing harm to yourself, is accepted as a mental disorder. Now, if you were faking the symptoms or lying about symptoms in order to get something other than the sick role, then it's malingering. And malingering isn't a DSM diagnosis, it's just a phenomenon. So you don't have a mental disorder, you're not mentally ill, you're just a faker. And this is when your motivation is for secondary gain, getting something good or avoiding something bad. So getting workman's comp, or maybe you're about to deploy somewhere, and you create 4 pain symptoms, 2 GI symptoms, 1 sexual symptom, and 1 pseudoneurological symptom. It's not somatization disorder, it's malingering, because you're lying about symptoms, or you're poisoning yourself, you're doing something to yourself, and you're doing it in order to get out of some unpleasant experience, and that would be malingering, which also can be hard to identify if the person is particularly experienced, especially individuals who are in the healthcare field. They're pretty good at faking illnesses. People who aren't in the healthcare field aren't as good at it. They may be a bit naive about symptoms, and may make up symptoms that are so unreasonable and unfathomable and inconsistent that they can be easier to detect. But again, more experienced, knowledgeable people, or people that just study hard, can do a pretty good job at faking being sick. And you need to rule that out as a possibility. But the tricky thing is, just because somebody gets secondary gain, just because somebody is getting workman's comp for their pain symptoms, doesn't mean that they're malingering. It makes it more likely, but not necessarily. They could have pain disorder. They could not be intentionally creating, faking, or producing a symptom. So it's sometimes a tricky thing to discern. Okay, so that's it for now for dissociative disorders and somatization disorders. And again, the key thing here overall is these are ways of coping with stress, and often really traumatic, stressful events, by either dissociating parts of the cognitive emotional experience, or by redirecting the stress in some sort of physical or somatic manifestation. That's it for now. Take care.